Hello, everybody, and we are coming back now. And I just want to thank you for joining us today once again. And now we have a second session. We will start with the patient's voice once again. This session will be focused on the current and future management of chronic cough. We have three excellent speakers, but as the first time, we now starting with the patient's voice and with the patient's video.
Estamos depois de muitas alterações e de otorrino, de oftalmologista, mudaram a boa do Symbicort esporádico para o uso diário. E o Symbicort passou a ser o medicamento que usou só em SLS. Pronto, e de facto estabilizou, estou a aceitar que é uma doença crónica que não passa. Neste período, também a referir há cerca de 3 anos, quando passou a parte mais crítica de Covid, fui operada 2 vezes ao nariz, portanto acabo também de ter sumix e sinusites, tinha pólipos que eu sabia na altura, respiro um bocadinho melhor, mas foi necessário também este ajuste de medicação e agora está mais controlada.
我觉得这个咳嗽就是这几年之内，应该说是不停的跑医院，不停的看医生，做了无数的检查，很多检查也在重复来重复去的在做，所以的话然后所以的话这个对我也是产生了很大的困扰。但是呢，经历过这么多的就诊经历，包括我在当地治不好的情况下，我现在也跑到了外地的大医院来就诊。目前为止呢，就是也是有一定的有一定的小好转，但是也并没有得到根治。这就是我这么多年的根据咳嗽得的进诊经历，也是浪费了很多时间和精力，也浪费了。
Wenn so ein Hustenanfall kommt, trinke ich, lutsche Bonbons oder nehme Kaugummi. Das ist das Einzige, was ein bisschen den Hustenanfall beruhigt. Untersucht wurde eigentlich schon alles. Die Lunge wurde untersucht, es wurde untersucht, ob es der Reflux ist. Ja, Allergie wurde untersucht, aber man hat keine organischen Ursachen gefunden.
Vou tomar medicação para melhorar e espero que descubram uma medicação que estabilize mais isto, eu já estou melhor, que estabilize e que resolva outras situações muito mais complexas que a minha. Fiz fisioterapia respiratória, não sabia, acho que é até bom divulgar este tipo de terapias e de facto vi que há casos mesmo muito complexos e que a tosse, no meu caso, não condiciona assim tanto, deixa-me extremamente cansada e menos produtiva, mas que para outras pessoas é de tal maneira que tínhamos colegas que usavam já uma bombinha, ou uns amigos uma garrafinha de oxigênio e realmente é triste ver ao ponto que as pessoas conseguem chegar e se preocupam. Essa parte preocupa-me se algum dia chegarem a esse estado.
然后有几次呢，我咳到非常胸闷、胸痛，我去了急诊，然后急诊给我拍了胸片，其实是没有任何的问题，然后就让我回去休息。我还有去看过另外一位医生，他就是说可能是新冠后遗症，让我多喝热水，让我多休息。但是呢，就是这样没有问题，然后让我多休息这样的情况下呢，我的咳嗽并没有好转，反而变得更严重了。然后我又去看了其他医生，医生说有可能是鼻炎后反流，说让我吃鼻炎的药，还有可能是胃酸反流，让我去吃治胃酸的药。我都有试过，但是其实对我的作用并不大，因为那个不是我本来的原因。然后我遇到了现在这位就是非常专业的医生，他给我做了很全面的检查，开了非常对症的药，然后我吃了之后呢， 马上就好了，基本上1个星期之内我就可以正常的生活、正常的运动。
Thank you once again to the patients who took part in our videos. Our first speaker in this session is Jen Butler, who is going to be exploring non-drug treatments for chronic cough. Jen is a speech and language therapist at Northumbria Healthcare Foundation Trust in the UK.
Thank you. I'll just share my screen and if you can let me know. Oops. Can you see the initial screen?
Not yet, Jen.
Hello? Yes, you can hear me and see the throat.
I can't see the
Okay.
presentation.
Oh, okay. Just be sharing. Oh, here we go.
Yep.
Put it on presenter view. Okay, now? Okay, so thank you, first of all, for inviting me to speak here. I think it's a real privilege to speak to people who are actually experiencing chronic cough. As mentioned, I'm a speech and language therapist in the UK. And I'm going to talk to you today about why we might consider non-pharmacological interventions, who often delivers these interventions, a little bit about speech and language therapists, because certainly in the UK, we lead a lot of the chronic cough interventions, and that can sound confusing to people because obviously and then I'm going to talk to you about the typical patient journey that we would go through with patients. So why is this important? So often preferences. So a lot of our patients that we see in the chronic cough clinic might say that they just don't want to take medications, or they might want to try something alongside some medications that they're on. Often with the interventions that we suggest and provide, there are no negative side effects or interaction with other medications that sometimes patients are on. It's also very both in the term of the environment, and that, we're not introducing new plastics, but also that patients can do these lifestyle changes and breathing exercises for as long as they want. Whereas often with medications, they're wondering, is this a medication that I'll have to take for life, which some people are okay with, but lots of our patients say they would rather not do that. We're also able to offer really personalised and bespoke interventions for people, recognising that everybody's cough is different, but also each individual that we treat and we support is different. So whether that be lifestyle, family, different circumstances that the cough can affect them, we can really deliver and tailor interventions to support each individual. And that leads on to, again, thinking this with the whole person. So it's important to say that our interventions can be delivered in isolation or alongside medications. So often it will potentially start alongside medications, and then hopefully people can just use our lifestyle and our breathing exercises independently in the longer term. So who often delivers these treatments? So it's often speech and language therapists, certainly in the UK experience, but also physiotherapists, and who have been mentioned already, but also psychologists. So we know that with people who've had a chronic cough, as lots of you know, it can have a huge negative impact on people's social and emotional well-being, but also upon people's day-to-day life and how they can interact with family members and at work. So we really think that's a really valuable role to have within the chronic cough team. But really the whole team, from the primary care to the secondary care, and all the nurses and doctors, everybody involved should have an idea of tips and tricks to offer patients to support their cough even before any medical trials have started. So why speech and language therapists? So historically, speech and language therapists specialize in communication. And as you know, one of the key forms of communication is to use our voice. And to produce voice, we take a breath in, it makes our vocal cords vibrate. And those vocal cords are also what produce the cough. So our speciality will be explained again in the rest of the presentation, but it's just important to reference this systematic review that has been done, which shows how non-pharmacological interventions can relieve the cough and improve quality of life. So what do we do? So obviously after people have had their thorough investigations, often lots and lots of investigations, as many of you have experienced, we try to pull these investigations together. So we'll look at the data that has been gathered in the referral letters or in other, and even non-referral letters. Sometimes we'll delve even deeper and we'll look into patients' ear, nose and throat reports, the respiratory reports, the gastroenterology reports, and we'll really try to understand what is happening for each individual. But then more importantly, we listen to them, and we have often the luxury of 45-minute appointments, which is very different to certainly in primary care, when doctors often only have about 10 minutes. So we listen to the triggers for your cough, how your cough presents, whether it's throaty, whether it's chesty, is there mucus, is there a tickle, and then also the impact that the cough has. We then try to make it all make sense. So we'll sit with patients and we'll try to unravel the often the very confusing pathway that people have been down and try to essentially build up a story and then again deliver an intervention that works for each individual. So often in our initial appointments, I'll just put my point of view on, we will start to try and make it make sense by helping people to understand the anatomy a bit more and where laryngeal sensitivity comes into the chronic cough picture. So you can see here, this is a cross section of a person. So we've got the lips and the nose here, obviously the lungs here. So we explain and we kind of discuss together about how to breathe. We breathe in through the mouth or ideally through the nose, and we breathe in down here, down to the windpipe towards the lungs. When we swallow, we eat and drink, we chew here, and it goes down the food pipe at the back. So the only reason we need to cough is if something goes down the wrong way. So if we're eating and drinking, something goes down into the windpipe, it will tickle some nerve endings, either on the vocal cords or down below the vocal cords, and it will send a message to our brain to cough to eject that material. Otherwise, if we've got a chest infection, you might have mucus down here. And again, it'll tickle the nerve endings and send a message to your brain to say cough, and you will eject it. What happens with laryngeal hypersensitivity is people can kind of smell something up here, or you might, so whether that's an aerosol spray, or you might experience a change in temperature, and that will tickle some nerve endings higher up, and that will send a message to your brain to do a cough. So you'll trigger a cough, but because there's nothing there to eject, you will cough and cough and cough, often to try and eject something that isn't there. It's a helpful thing. Often cough is a very useful thing when it works. So a helpful cough can save our life. So if something goes down the wrong way and potentially could choke us, that cough is there to save us. So it's very difficult to challenge that belief if we feel that we need to cough. And trying to make sense again of the laryngeal hypersensitivity and reassure the brain that if you don't cough, nothing bad is going to happen, can be a big key role in our intervention. And this is the kind of view that we'll get. So if we put the camera, a little nasendoscopy in the nose, so it kind of slides in the nose and sits at the top and voice box. So these here are the vocal cords that sit on top of the windpipe. You see the windpipe down there. So when we're breathing, we want the vocal cords to be nice, wide and open so we can breathe freely. When we hold our breath, our vocal cords squeeze together like this, so we can't get any air in or out. And when we do a cough, the vocal cords slam together to eject the material. When we're producing voice, the vocal cords come together nice and gently. You can see the white lines there, and there's no kind of squeeze around the vocal cords. So when we swallow, we want the vocal cords to squeeze off like this, and then this structure here is like a little lid that goes over the top of the windpipe. Food will go down the right way into the food pipe. Sometimes you might get crumbs stuck in this little pocket here or this little pocket here. And if you've got hypersensitivity, your brain might interpret that as being in the wrong place and trigger a cough. But because it's not in the windpipe, that cough won't be effective. What I'll also use these pictures to explain is why your voice might go after you've been coughing. So typically, we like the vocal cords to come this. Sometimes the muscles around the vocal cords become very squeezed and you might get a really tight, strained voice. And that is about how the muscles are squeezing around those vocal cords. In extreme cases, patients can get a lot of inflammation on their vocal cords as well. Their vocal cords might get a bit fatter, which will give them a lower pitched voice. Here are some video on helpful cough. So here again, to orientate you, we've got the vocal cords here, and this is that structure that flips over to make sure things go down into the food pipe. So this patient did a cough and she swallowed and something was about to go down the wrong way, so she coughed to get it out. So that is a helpful cough, and if she didn't do that cough, she potentially could have choked, which would have been very challenging. This next one, however, shows an unhelpful cough. So this patient has got a really healthy voice box, but when she talks, her vocal cords tickle each other and it triggers a cough. So you can see there, the vocal cords were tickling each other and triggered the cough, which is a little bit like scratching a midgie bite or scratching some eczema. So the more you scratch it, the worse it can often get. So the next question is, why does it start? So often a chronic cough with laryngeal hypersensitivity will start action. And it can sometimes be made worse if you say, for example, if you've got asthma and you're taking inhalers that have got dry powder and you're not using a spacer with them, that can make things like the lining of your throat a little more irritated. If you've got acid reflux, sometimes the reflux can come up into your throat. The lining of your throat is very thin compared to the lining of your stomach. So sometimes potentially the acids or the enzymes can irritate the lining of your throat and make it more sensitive. If you've got any nasal disease, it can also make symptoms worse. So this can either be if you've got thick mucus in your nose, it can drip into your throat and make it more uncomfortable. But also if you've got a blocked nose and you're not able to breathe through your nose, you can't filter the air. So if you breathe in through your nose, it warms up the air, it humidifies the air. So by the time it reaches your throat, it doesn't tickle quite as much. Whereas if you breathe in through your mouth, it could really just suck in that dry, irritating air that hits the throat and triggers that cough reaction. If you smoke or vape, again, it's bringing in more irritants into the throat that can make it less healthy and more irritable. If you're dehydrated, that can also make the lining of your throat less healthy and more likely to be reactive. But also noticing, so our patients often say that their throat is, their cough is worse if they're on the bus or if they're in church or in the theatre. And it's often because they're sitting really thinking about how their throat feels. And if I use an example now, a lot of you are probably sitting down, you probably weren't aware of how it feels on your thigh sitting against the chair because you weren't thinking about it, but now that sensation is. So again, a lot of our intervention can work on distraction techniques as well. So why doesn't it go away? If we don't manage these factors, it can be really challenging to control the cough. So a lot of our intervention looks at how we can really look after how healthy our throat is. This video again shows that it can be a vicious cycle in the throat. So this is quite a severe cough. So this shows that if you've got an irritation in your throat and you do a cough, it can make it more irritated, it can make you cough again and kind of keep going around in circles. But also from this, I'll also like to highlight that lots of people try to not cough by holding their breath. But if you hold your breath, then the air in your lungs is building up, and you often end up then with a really severe cough, almost like an explosion. So again, if we can kind of cut in this cycle to reduce the cough, that can reduce the irritation, which can reduce that urge to cough. So what can we do? So we look at throat health, so tips to look after the throat, which I'll come on to. We look at breathing exercises. So especially for people that are mouth breathers, we try to encourage people to breathe through their nose. Again, if you do a sniff, it forces the vocal cords open and it prevents that cough from happening. We look after people's well-being. So as already has been covered a lot, the impact of cough can have a huge impact on people's emotional well-being. And also we can look at kind of specific interventions to support people in particular settings. So we have some patients, for example, where the cough is always worse if they're in meetings at work. So we can give them different strategies for that compared to when they go into the freezer aisle in a supermarket. It's different strategies for different circumstances. So top tips for throat care include increasing hydration. So again, we'd support kind of little sips, small and often. Inhaling steam can be good. If you've got a blocked nose, making sure that you kind of try a nasal douche or getting in touch with your doctor about any other nasal sprays. Ensuring any reflux is managed, again, often using your medical colleague, your doctors for support with that. And for example, if you're using inhalers, making sure you're using a spacer. There are a range of different breathing techniques, which I don't have time to go into today, but we do have evidence of kind of examples on the website that I'm going to show you towards the end. And I'd just like to end with this quote, which I think is really powerful, and certainly in the world of chronic cough, that the good physician treats the disease, the great physician treats a patient who has the disease. And I think that's what non-pharmacological interventions are really great for, is that can we really personalize interventions for you. So thank you very much. And here's a link to our website that we've developed that has got a bit more information that you may find helpful. Thank you.
Thank you, Jen, for that wonderful talk. Next up, we have Professor Alan Morice, who's going to be looking at drug treatments for chronic cough, both now and in the future. Professor Morice is Head of Respiratory Medicine at the Centre for Cardiovascular and Metabolic Research at Hull York Medical School in the UK. He also leads the Hull Cough Clinic. Over to you, Alan.
So hopefully you got my screen on the video. Is that right?
Yes.
Yes.
Excellent. Okay. So I've been fascinated by cough, since I was a medical student, really, and that's a long time ago. So we've been treating cough for centuries, really. So the first person to write about it was this guy, John Mudge, in the 18th century. And he published this book, Radical and Expeditious Cure for Recent Catarrhous Cough, right? And this was, the active ingredient was opium. Opium is extract of poppies, and it produces drugs like morphine and many other drugs within that. And you can see how he delivered it. It was a beer tankard, basically, and you put the opium liquid in the bottom, and the holes at the side of the beer tankard went through, and it bubbled up, and you inhaled it. Now, inhaled morphine isn't very good because it actually makes you cough more, but oral morphine is one of the commonest things that I use in my clinic. It's low dose morphine, 5 milligrams twice a day, and it can absolutely stop the cough just like that. It's fantastic. But it only works in about a third of people. And throughout the conversation we've been having today, people have been saying this works or that doesn't work. And people are individuals. We're all individuals. And some patients respond very well to this low-dose opiate therapy. So I would suggest that if you've not tried it, a trial of just a few days' worth of low-dose morphine is a thing that can absolutely cure the cough, and it's very safe in the long term because we're only using low doses. No point in going up the doses. If you respond, you respond, and if you don't, you don't. The problem is for us in the cough therapeutic world is that we're trying to show that to the regulating bodies that cough is improved. And cough is not a continuous phenomenon. It's an episodic phenomenon. So at the top here, we've got a graph of patient coughing. So they start off at 1300 hours, i.e. 1 o'clock, and they're coughing quite a lot. They've probably just had their lunch, and then the cough diminishes during the day. And then at 8 o'clock, 2000 hours, they start coughing more. They've probably just had their tea there. And then it goes away, and at night, people hardly cough at all. And then when they get up in the morning, 9 a.m., it starts again. Typically, the cough starts as people get up in the morning. Cough on rising, I call it. And the figure below that is it per minute. So you can see it comes in intense bursts. You have coughs, which are bouts or fits, or a number of words describe it. But these fits that people get are not uniformly distributed. And in most of the literature, people have tried to measure the cough and then averaged it out over 24 hours. And cough is much more granular than that. So what I've done is try to divide up the cough into the time spent not coughing, i.e. the relief of cough, and the number of coughs when you're in coughing. So that's the intensity or density of coughing. So you can see the chap got up at 9:30 on that day and coughed like blazes. And then there was a period of time when they weren't coughing, and then the cough continued on at about 10:30. So to enable me to do the analysis of this, I'd like to try and get your opinions, because it should be patient-led, this process. So we should be going to the Mentimeter now. And if you haven't logged on, if you would be kind enough to log on to the Mentimeter. And what I'm asking with the first question, I've got 3 questions. So the first question is that we all cough in different patterns. And if you have had a coughing bout, how long is it before you know that the bout has finished? I think we've got the wrong Mentimeter slide up there. If you want to put your answer in, you can do it in the chat, please, and then we can record this, and I will use this to inform the way we analyze the cough, because nowadays we can analyze cough using continuous cough monitors. It looks like the chat is probably going to be the better way of doing it.
We seem to have a problem moving slides, so I'm going to share my screen with the results coming up.
Okay, so we'll see the results of this question. How many minutes is it approximately before you realize that you're not coughing anymore? 0, 5, 10, 15, 20, 25, or 30? Excellent. So I did a poll with some of my patients in the clinic, and they came out at about 15 minutes, but some of you are saying 5 minutes, which is fine. We are reanalyzing the cough recordings that we've got to enable us to know whether there's a window when people can recognize that they're stopping coughing. Fantastic. So the next question is, we all have occasional coughs, and how many coughs is there before you know that you are having a bout of coughing? So I will cough, and then there's nothing happening after that. But there are people, and I'm among them, who have bouts of coughing. Cough, 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 cough. And so how many coughs make a bout? That's what we want to know. So we'll wait and see whether we get any responses on the Mentimeter. How many coughs make a bout or an attack or a fit of coughing? Again, you can post it in the chat if you want. No, it's not the length of time that you're coughing. It's how many coughs you think happen before you can say, this is a bout of coughing. Okay, brilliant. And we'll move on to the next question then, the last question. What's more important to you as a patient? Is it a decrease in the number of coughs that you have in a day, an increase in the time spent coughing, not coughing, or a decrease in the number of fits that you have during the day? And you can move that first, second, and third around, so you can move those things about. Either that, or you can put it in the chat. Which is most important for you? A decrease in the number of coughs, an increase in the time not coughing, or a decrease in the number of fits of coughing? Excellent. People are putting it into the chat if they're not getting the Mentimeter to work. Well, thank you very much. That will greatly help me determine what is important to the patient with their cough. There we are. Perfect. An increase in the time spent coughing, which is what I call relief of cough. Okay, I'll start sharing my screen again now. Where are we? Lost my... I'm just trying to get the view up that I want. There we are. So we've been through the questions. Sorry, my presentation seems to be stuck. There. Okay, some new drugs. So we've got morphine that we can use in patients, low dose, as I say, but there are other types of opiates. And this is one which is in development, and it's been used in a couple of clinical trials. We've just finished the clinical trial in called River in chronic cough, and analyzing it the way that I've just described, you can see that in this trial, which is in pulmonary fibrosis cough, that it trebled the length of time that patients were not coughing. They were relieved of their cough 3 times as much with this opiate drug. And it's not like morphine. It doesn't have the same side effect profile. It binds to a different receptor in the brain and suppresses that horrible tickle that patients get, the cough hypersensitivity. And similarly, the amount of time that the patient was coughing was greatly reduced with this opiate drug. But as I say, it's not like morphine. It's a different receptor that it binds to. And when you looked at the amount of coughing when people were coughing, there was a great reduction here in the number of coughs that occurred when people were coughing. So this way of analyzing it allows us to look at what actually matters to the patient. Because if we try and correlate average number of coughs over 24 hours, there's very poor correlation to what you, the patient, says. Whereas this way, it improves the correlation by looking at the individual aspects of cough. The cough is broken down into individual segments. So a lot of people have talked about what is the cause of this, and almost all the tests that people are usually routinely subjected to are normal. The doctor says it's a complete mystery why we got this cough hypersensitivity. Well, what we do is we think that the cough is mainly a problem with the gullet, the esophagus. And because you go and see a respiratory doctor, they only look at the lungs. If you go to a gastroenterologist, all they understand is acid reflux. And the disease, I believe, is due to non-acid reflux. So blocking the acid, which is you do with drugs called PPIs, lansoprazole, etc., that doesn't have any effect on the cough because it's not acid. You reflux, but it's non-acid. It's a bit like a belch, but you don't notice it. And up comes this gaseous mist, which is not acid, and it lands on the voice box, irritating the voice box, but it goes up the esophagus, the gullet. And here we've got, we've done, well, more like 400 patients now. And as we know, most of the patients with this cough are ladies, and they have a high, low score only on acid reflux. But here on the right-hand side, the far right, you can see that there is a normal swallow. So the patient swallows, and you can see the red line going down and going black, and it goes into the stomach. But this poor person has no valve at the bottom. And so at the bottom, you can't see this, the lower esophageal sphincter, as it's called. So there is no valve, and the patient is able to reflux. On the left-hand side, you can see a normal swallow on the right-hand side. But on the left-hand side of this bottom trace, you can see that there is a gap. The swallow doesn't work, and the lilac color in the middle there is the water that they've swallowed to make the do the test, and the water just sits in the esophagus, irritating the vagus nerve. So I believe that the majority of, this study demonstrates that the majority of ladies who have this condition, and it's 2/3 ladies, they have poor swallows as the ultimate cause of it. There is a drug that you can get now, and it is working on the swallow reflex. It is azithromycin. It's a very commonly used antibiotic. It's 250 milligrams once a day tablet, and it works in a considerable number of people. But doctors don't understand how it works. It does work in a whole range of different respiratory diseases. So if you've been diagnosed as asthma or COPD, these drugs are recommended in these conditions. But the ERS guidelines only recommend it at the moment in chronic cough for a productive cough, because nobody has done the study. But we have, and we've just got the results this week. So if you look at that graph, you can see that the cough starts at about 12 and goes down to about 7. So azithromycin given for a month reduces the coughing by about half. Now, it doesn't work in everybody, but it's worth a try if you want to try this 1 tablet azithromycin for a month. And if your cough is better, just continue, because it's a very safe drug. So that's a tip for today. What about tomorrow? Well, we now know how most of cough is produced. Something damages the cells on the lining of the throat or the nose or the airways or the epithelium of the esophagus, and it causes release of this substance ATP. That's adenosine triphosphate. And that substance irritates the nerves. So that's where you get the tickle from, this irritation from the release of this substance ATP. And it goes on to the receptors on the end of the nerve, which is in the box on the right. And you can see that there are two receptors there, but particularly the P2X3 receptor. And this drug, gefapixant, has just been licensed in Europe. Excuse me. Gefapixant blocks this receptor on the end of the nerves and stops the irritation. It works in about 2/3 of people, and it reduces the cough enormously. We've had Kaylee give a demonstration earlier on of what we've found with asking the patients, but about 2/3 of patients respond really well to this, and its only side effect is a funny taste. And I have had great success treating patients with this drug. Unfortunately, it's not available for patients in the UK under the NHS. So we have to prescribe it on a private prescription. But this drug is dramatically effective, and hopefully over the years we will get other drugs. And so we're doing phase 3 studies on these other drugs, and a lot of the patients I'm talking to have volunteered for studies to do on these drugs. So not only is there gefapixant, but there are also members of this other class. There are also in development nerve blocking agents, so you can block the irritation that you feel. And there's also drugs which cool the throat and prevent that tickle from irritating you. So there are lots of drugs in development. But when we've asked patients about their treatment with gefapixant, the pain has improved. They can now cope with what was really distressing. The cough impacted them, but they're now under control. But on the right there, you can see, I can't say the drug has done anything or has any effect. So the treatment for chronic cough is a question of trial and not error, but trial and trial and trial until you find the drug that suits that individual patient. So just to finish up with, we've got a website which has an opportunity to talk to a AI that I have created, and it's called Alan. So if you want to visit Alan, you can either scan the code there, or you can hit Alan. But if you go to the Tussogenics website, that's available for you to see now. And also, if you want to volunteer for clinical trials, you can type your email in, and we will then send you a screener to be able to get yourself volunteered for clinical trials near you. And this is Alan. Basically, Alan is an AI that I've created. It's from the European Respiratory Society guidelines, the British Thoracic Society guidelines, and a few papers, other papers that we've put in. So it's based on the scientific literature. But remember, Alan is just a bot. It doesn't think. It just gives you the information that you are asking for. So if you type into the bottom the question that you have on the cough, it will answer as best it can. But it's, as I say, it's not me. It's a computer program which allows you to talk to. And you can talk as much as you want. Ask any questions. We've got quite a few questions on the chat, but you can talk to this program, and it will give you the answers based on the scientific literature. So please have a go with Alan if you've got other questions and want to know more about cough. And I think that's the end of my talk.
Well, thanks, Alan, for introducing, for talking about the present and the future of the cough treatment. Now, Dr. Christian Domingo, who is going to be giving an update on the NeuroCough registry and cough clinics in Europe. Professor Domingo works in the Department of Medicine at the Autonomous University of Barcelona in Spain.
Thank you, Sandeep. Hello, everybody. Good morning from Barcelona. I have to say, first of all, that I feel honored for having had the opportunity to participate in this meeting. And I've been told to explain to the audience what's NeuroCough. This is my conflict of interest. Well, NeuroCough, I was thinking about how to define it. NeuroCough is probably a group of friends who met several years ago in an ERS meeting organized by Lorca McGarvey, the first president of director of the NeuroCough, and Professor Alan Maurice, who maybe from now I'll be calling Alan Maurice. We'll have to see. Well, we met several years ago, as I said.
Christian, we're having difficulties hearing you. We can hear you, but your sound is low, so I don't know if you can put your mic up.
You can hear me better now?
No.
There's an echo. Microphone, maybe?
Yes, that's better.
Okay, I'll remove this then. It's good for nothing. Well, as I said, a group of friends interested in chronic cough, interested in helping patients with chronic cough, and interested in improving the quality of life of patients with chronic cough. When we talk about the disease, the first thing we have to realize is how relevant this is for the population affected. And we then talk about prevalence. What does prevalence mean? It's the proportion of people suffering from a disease. When we say prevalence of 10%, it's 1 out of 10 people suffer from the disease. 5% means 1 out of 20 people. In a study performed in Spain, we found a prevalence of around 5% of people suffering from cough in the 12 months previous to the survey. This is similar data to that found by Virchow in Germany. In some other surveys, the prevalence has been found to be a bit higher, between 5 and 10%. In any case, this is a very relevant disease. What were the objectives of NeuroCough? Well, to create a multidisciplinary team of world-leading researchers, clinicians, people from academia, combined with the pharma companies, the industry, and patients suffering from chronic cough. This should allow us to create a registry of Europe-wide specialty cough clinics, to establish a Europe-wide registry of clinical trial-ready chronic cough patients, that is, patients prepared to participate, as Professor Ali Maurice said, to collaborate in clinical trials to try new drugs, as well as to promote the education and patient and public engagement in the field of cough. Until now, we can see in blue the countries participating. Not all Europe is participating, is collaborating, but we've got 12 sites already who have already recruited patients. And until the ERS meeting, there were a bit less than 1,000 patients included, recruited for the NeuroCough registry. Which are the characteristics of these patients? Well, we have here summarized that we have data from around almost 1,000 patients from across 12 sites. Which are the demographics and clinical characteristics of this patient? Many of the patients attending this meeting will probably feel that these data are representative of themselves. The mean age is around 60 years. 3 out of 4 are female. This is in the in Europe, it is not uniform all around the world. I just read a paper that in Guangdong, in China, the percentage was 50-50. But at least the data from NeuroCough are this. The duration of the cough is 12 years, which is a lot. Patients have been suffering from this disease from a mean period of 12 years. And those included have a moderate disease, according to the Visual Analogic Scale and the Leicester questionnaire. You know that we perform a lot of questionnaires when we are included in one of these trials. We need these questionnaires to categorize the patient. This represents the precipitants, the trigger factors that can cause cough in our patients. As you can see, in more than half of the patients have 5 or more triggers. Which is the cause of the disease? Well, in 40% of the patients, the cough can be considered idiopathic. Idiopathic means that we don't know the cause. It's the language we physicians use to describe, then we ignore the cause. It's better to say idiopathic, a word that not everyone understands, especially patients, than accepting that we ignore the cause. We can also define cough as unexplained chronic cough or refractory chronic cough. The difference is that in refractory chronic cough, we've got a cause, that a disease, a problem, a characteristic that can develop, that can be the responsible of cough. We treat this problem, but the patient does not improve. This is what we call refractory chronic cough. While unexplained is the same than idiopathic. We have no idea about what is happening. As you can see, in almost 40% of the patients are diagnosed of refractory chronic cough. And in some other gastroesophageal reflux, post-infective asthma, chronic rhinosinusitis, that is postnasal drip, and other cases. And these are the conditions by site. As you can see, there are some differences across the center. This depends on many aspects: the referral pathways, the interest of a center in some pathophysiological, in the study of certain pathophysiological ways, that is, the study of certain characteristics that can help us to explain the cause. It can also depend on local guidelines, as well as the terminology used, which is not uniform all around the world. Many of these patients have received treatment with PPI, inhaled steroids, many drugs. And in a huge percentage of cases, there is no response, as you can see in dark green, no response. Until now, we haven't had a very specific drug against cough. Now, with the P2X3 inhibitors, we will be able to prescribe the first drug designed to treat cough. Which are the complications of this patient? Well, I think we should give special relevance to the stress urinary incontinence, which is higher than 40%. And I would like you to present the results of the study we performed in Spain, in which we found that around 45% of the females had severe urinary incontinence. In half of them, the problem had been correctly diagnosed by a physician, but in 22%, the problem was underdiagnosed, had not been identified, because many times females do not refer it. This obviously decreases the health status and has a greater impact of cough. The severity of the patients included in the NeuroCough, please observe that moderate and severe are the big majority, according to the visual analogic scale, as well as to the Lister questionnaire. That is, patients included in NeuroCough are quite severe. Well, to summarize what we've been saying, we could say that NeuroCough is the first pan-European chronic cough registry. Refractory chronic cough represents more or less 40% and is the most common condition with prevalence across sites. Other entities such as gastroesophageal reflux, asthma, and upper airways condition remain to be common. Treatment with largely poor response and severity and impact are relatively similar at baseline and at 12 months. And I would like you to show a video of a patient of mine who suffered from chronic cough. Some of you might identify yourself with this patient. This is just to show if any authorities is connected, any people from the administration, just to show them how these people suffer. Imagine that this patient have 15, 20 episodes in a day of these cough attacks. And now, to illustrate what has been happening, what have we been doing with chronic cough? This child sees the monster, and then he covers his face. By the fact that covering the face, he doesn't see the monster, he feels that the monster does not exist anymore. This is what we've been doing with chronic cough. But when he removes his hands or his face mask, the monster remains to be there. This is what has been happening. We have ignored the disease because we didn't have any treatment, but now we have new options and we should not ignore the disease anymore. Thank you for your attention.
Thank you, Christian. It was very good, interesting, informative presentation. I feel proud to take part in the NeuroCough and to be with you and many of other people interested in chronic cough in this project. And thank you very much for the ending of your presentation, which brings us a lot, us and all the patients, a lot of hope. We should just look at the face of the chronic cough and hope that the treatment will be better and better. And now we have a time for questions and answer. There is few of them in the chat box, and some of them has already been answered. Thank you, Alan, for that. I'm very sorry, but we have to shorten the time of Q and answer. But I will just try to ask the question. It was posed by one of our attendees, and I would like to ask for the answer. Jen, do you know if it's convenient, is it helpful to connect speech and language therapy with antitussive drugs, or is it more efficient or not?
What was that? Sorry, was it the one about to do them both at the same time, or?
I mean, is it connecting non-pharmacological intervention with treatment is helpful, is more efficient than some pharmacological treatment?
I think it depends on the patient. I mean, we certainly in our experience would go down the non-pharmacological route first, and we get really brilliant outcomes. But understandably, for our intervention, people need to be able to have the time to commit to the exercises and to the lifestyle changes, and some patients struggle with that. So they might prefer to take medication. But what I would say is from the trials, it's not 100% of patients that do well with medication. So and it's difficult to tell which patients will do well and which won't. So certainly if we can do some non-pharmacological interventions alongside the trials, I think that will always be.
Well, missed you for a short
20
time?
years sometimes, and it's hard just to stop the cough and go back.
If I can interrupt there and
Stop
say
the
that
cough and go back, things can help as well. Oh, sorry.
so they're not mutually exclusive. So you can do both pharmacological and non-pharmacological interventions. And I believe that a lot of the benefit to the patient is actually talking to them sensibly about cough, because people feel isolated. They've been to doctor, and nobody knows what the cough is. It's a mystery. But it's not a mystery, really. You can predict that people will cough with eating and talking, and it's often positional when you sit down and lie down, when you go to bed at night, and then when you get up in the morning, you cough. So it's got a pattern. People have different patterns, but there is a recognizable pattern within the cough, and it's due to hypersensitivity of the nerves. And if you explain it to patients that it's like a burn on the skin, if you blow on it and it hurts, the same is happening in your throat, you have hypersensitive nerves there, all of a sudden there's an enormous amount of relief. And patients will often say, "Oh, you mean you understand what's going wrong?" And that explanation really aids the patient. So I think that both pharmacological and non-pharmacological treatments are very valuable in this particular condition.
Totally agree. May I ask to Christian, do you have a lot of speech and language therapists in Spain? I know that the situation in the United Kingdom is quite good, but I'm curious, how about other countries?
Unfortunately not. We don't have specialized speech languages. We do not. So you have anyone from the UK who wants to travel and live in Spain with the good weather?
That was definitely a question to John. The situation in Poland is the same. We are trying to get in touch with speech and language therapists and ask them, encourage them to treat our patients, and we just look at the results from the United Kingdom. And there is one more question to Alan about your opinion. Do you think that avoiding hot liquids could help for cough?
Well, people vary very much in their sensitivity to change in temperature. So some people are set off, a lot of people are set off by cold, for example, but there are other people who are set off by warm temperatures. And it's a very variable phenomenon. It's all to do with the distribution of the receptors for hot and cold in their throat. I would say that it's an individual thing. Some people, as I say, are set off by cold, but then on the other hand, the drinking can improve the esophageal motility. So a cold glass of liquid can actually improve the cough. So it's an individual thing. As a patient, you should look to see what sets you off, what your triggers are, because they may differ from another patient's triggers. But it's all a sensitive, a feature of the hypersensitivity of this nerve, the vagus nerve that controls your cough.
There are more questions. An anonymous attendee is asking, how long could it take for speech and language therapy to improve a cough? Or is it possible to do it online?
Can you hear me?
Yes.
I don't know if my internet, yeah. So we typically have about 3 sessions and we get significant improvements with that. We do offer online treatment in our department. I think it's better face to face, but I think online is better than nothing, because again, you get to explore things, and you can certainly practice the exercises, symptoms. So we have aerosol sprays. Oh, it says my internet's unstable. And can you hear me still?
Quite good.
Oh, sausages. Yeah, so we'll trigger the symptoms in clinic. So we have cold water, we have food, we have lots of things, so we can guide intervention specifically, but there's nothing to say that people couldn't present things to themselves online, and we can observe and guide that way.
I think we have we have still one more question. Why do the patient cough at night? And I would like to ask Christian for the answer. What's your opinion? Why the majority of patients cough mainly during the day? But if you have patients who cough at night, what would you think about the reason or the trigger?
Well, if you exclude other diseases such as cardiac failure, and now I'm thinking about the last 3 patients that were referred to me for chronic cough, and whose chronic cough deteriorated during the night when they were lying down. They were suffering from cardiac failure, you know. So you have to exclude other causes. Not everyone that causes cough is just related to the larynx, or you have to differentiate between the symptom of the reflex, the symptom of a disease, and the disease itself. So we're now referring probably to the disease itself. In some cases, it's been advocated that reflux could be the cause, but as I've heard to explain several times to Professor Maurice, reflux is very active during the day when you're in the when the patient is standing up. So although mentally we could think that reflux is the cause, the experience and the scientific information tells you that this is not really the cause. It depends on, there are many triggers that can influence cause, as I showed and Professor Maurice pointed out. So it's a mixture of them. In some who suffer from asthma, if they have dust mites in the room, for instance, they can deteriorate, and this would be caused by a deterioration in asthma. So the precipitants are very, very different, and many patients have several precipitants of cough.
The one I've noticed most is that patients who have a cough predominantly at night, they often have a hiatus hernia where the stomach has slipped in the chest, into the chest, and then the valve holding the stomach contents in is weak because it's not supported by any of the muscles. And so they tend to reflux more than people who have a normal gastroesophageal junction.
Thank you very much. I'm afraid that we have to finish the questions and answers part, and I would like to hand over to Caroline.
Now we're coming to the end of our day, and we really hope you've enjoyed it, found it useful, and gained helpful insights into chronic cough. We'd like to ask you a final poll question. We're repeating the one at the beginning of the event. After today's event, how much knowledge do you have about chronic cough now?
Can we see the answers?
I think they're just coming through.
Okay, I'm not sure if we can see.
Well, I can see it online, but oh yeah, there we go. Yeah, so it looks like the knowledge of chronic cough has improved from the beginning of the conference, which is great news. Now I'll hand back to Marta.
You're on mute, Marta.
Marta, you're on mute.
I'm sorry. Thank you very much. Thank you, Caroline. And I just want to make some requests. We would like to ask you to invite you to keep in touch with us, to sign up to the ELF newsletter, to get involved by social media or by mailing us to find out more about the NeuroCough project. And the patients, the ELF cough patients advisory group is welcoming new members. So if you feel happy to join them, please get in touch with the ELF patients advisory group. And I think that's time to sum up. We have a lot of new information, very interesting information, and the take-home messages, most important, are about the impact, enormous impact of chronic cough on patients' life, about the complications of chronic cough, especially about the cough-related stress urinary incontinence, about options for non-pharmacologicals and novel cough drugs, which we hope that will change the journey of patients with chronic cough and their perspective. And at the end, I would like to thank very much all the speakers and the patients from the cough patients advisory group, especially Claire Williams, who make a lot of work for this conference to come through today. Thank you very much, and I just hand over to Sandeep.
Thank you, Martha. Well, now we have come to the end of the event. So, well, thank you all for joining us today. Your participation and insights make this webinar a success. We would like to special thank to speakers, to the members of the cough patient advisory group, the NeuroCough team, the ELF staff team behind the scenes, and everyone who helped to promote the event, and to everyone who joined us today. And I would like to remember you that the recording of this event will be published on the website following the event. You will be able to find the links on the event page or in the chat too. And that's all. Thanks a lot. And of course, just a quick question. Quick information. A short feedback form will be sent out to everyone who registered for the event. And we are also putting the link in the survey in the chat. So please complete it and let us know what you think. Thanks a lot.